everybody. Welcome to Advanced Trauma Module 2. My name is Rob Adamski. I'll be your instructor for today. We have 3 topics for today. The first is shock and hemorrhage. Second is IV therapy for pre-hospital care providers. And third is general pharmacology. So we have 6 main objectives for the first part of the class. The first is we're going to review the epidemiology, including the morbidity and mortality for shock and hemorrhage, i.e. how it injures our patients and how it kills our patients in the pre-hospital care setting. 2, we're going to describe the various types of tourniquets that are available in the pre-hospital care setting. 3rd, we're going to explain the pre-hospital applications of tourniquets or how we use them in the field. 4th, we're going to identify common types of hemostatic agents and how they work, the pathophysiology that's involved with them, and how they help stop hemorrhage. 5th, we're going to discuss the use of hemostatic agents within the pre-hospital environment by EMS providers. And then finally, 6th, we're going to discuss the pre-hospital use of tranexamic acid, or TXA, in patients with hemorrhage and hemorrhagic shock. Those are our 6 objectives. So from an introduction standpoint, why is this topic of hemorrhage and shock important? Why should you care as an EMS provider? And why should you listen for the next 2 hours? Well, it's important because shock and hemorrhage will kill your patient without a doubt, all right? And if you look at that last bullet point there, according to the CDC, or the Centers for Disease Control, unintentional injury or trauma is the leading cause of death for people under the age of 45. So therefore, the vast majority of our patients who are under the age of 45, if they are going to succumb, all right, to whatever malady they have, why they called 911, it's going to be because of trauma. And therefore, knowing how to treat shock and hemorrhagic injuries in the field is of critical importance for EMS care providers. Now, to understand the concepts of shock and the pathophysiology of shock, i.e. how shock injures and kills our patients, we need to do a quick review of the circulatory system. What is the whole purpose of the circulatory system? All right, it's one of the important body systems we have as human beings. Now, the role of the circulatory system is to provide perfusion to our vital organs, our heart, our brain, our kidneys, etc. And what is perfusion? Perfusion is adequate blood supply or sufficient blood supply to provide oxygen and nutrients to our vital tissues and organs, i.e. the heart, brain, and kidneys again, all right? And this is equally important, a lot of people forget about this, remove toxins and other waste products that are a normal part of metabolism, such as carbon dioxide, lactic acid, etc. All right. Now, the components of the circulatory system consist of, look at it, if you want to use, you can use a plumbing analogy. All right. So we have several main components. The first is the pump. All right. And that would be the heart. Second, we have our blood vessels. All right. Arteries, veins, capillaries, etc. All right. They act as the plumbing or the tubing. And then finally, we have the fluid or the liquid for that whole plumbing system, which is our blood, all right? And you have several main components to the blood, all right? You have the liquid portion, all right, which contains plasma, all right? And that includes various electrolytes, your clotting factors, etc., as well as the formed cells component of your blood, which has erythrocytes or red blood cells, which have their primary purpose is oxygen carrying capacity. Second, we have white blood cells or leukocytes, which act as part of the immune system, help protect us from various pathogens and infections, such as bacteria, viruses, etc. And then finally, we have thrombocytes or platelets, which help with the concept of hemostasis or hemorrhage control. Now, if you look at the circulatory system, all right, we have the heart component, which is the pump, all right? We all know this is, a basic review. This is Anatomy and Physiology 101. Your heart consists of 4 chambers. you have the two upper chambers, which are the atria. You have the two lower chambers, which are the ventricles. The heart is split into the left and right half. The right side is the low pressure side. That's the part of the heart that pumps the blood to the lungs. So therefore, it can be reoxygenated and also dump off waste products like carbon dioxide. Next, you have the high pressure side, or the left side of the heart, all right? And that's what's going to be the systemic side of the circulatory system, and that's what's going to pump blood out to the entire body, all right, to our various organs throughout the body. Now, as far as the plumbing side goes, all right, our blood vessels, you have the largest artery in the body, which is the aorta, all right, and that's where the blood's going to leave the heart. You then go to arteries, all right, which by definition, anatomically, are thick-walled, very muscular structures, all right, and they're able to constrict and expand depending on the needs, the physiologic needs of the body. Then you proceed to smaller arteries or arterioles. And then finally, at the tissue level, at the organ level, you're going to find capillaries, which are single cell layer thick cells. And that's where diffusion takes place. All right, you have the oxygen and the nutrients leave the circulatory system, go into the tissues. And you have the metabolic waste products like carbon dioxide and lactic acid leave the tissues and enter the circulatory system so they can be eliminated. Then on our way back to the heart, we start out with venules, which are very small veins. Then we proceed to veins, which by definition are thinner walled blood vessels compared to arteries. However, they do have unidirectional valves, which helps maintain proper blood flow. And then you have the largest vein in the body, which is where the blood is entering the heart, all right, and that's the vena cava. Now, it should be noted that when we're talking about arteries and veins, remember, arteries always go away from the heart, all right? Their blood flow always goes away from the heart. Veins, the blood flow always goes back to the heart, right? So that's your 30-second idiot's guide to the human circulatory system. But remember, the main function from a physiologic standpoint of the human circulatory system is to provide perfusion or adequate blood flow, and therefore oxygenation and delivery of nutrients, as well as removal of waste products like carbon dioxide and lactic acid, all right, to our tissues and therefore our vital organs, all right, the heart, the brain, the kidneys, the lungs, etc. And following the red blood cell, as it travels throughout the body, all right, we're going to start on the venous side of the circulatory system where the red blood cell or the erythrocyte is loaded with carbon dioxide, right? Then that's going to travel via the largest vein in the body, the vena cava, back to, remember, veins always deliver blood back to the heart, all right? It's going to be delivered via both the inferior and superior vena cava to the right atrium. All right. And then moving from the right atrium, the blood's going to pass through the tricuspid valve into the right ventricle. It's then going to move via the pulmonary valve, move through the pulmonary valve into the pulmonary arteries. Remember, blood flow with arteries always goes away from the heart. And then once the erythrocyte or red blood cell reaches the capillaries in the lungs, it's going to off-gas or offload carbon dioxide, and it's going to reuptake oxygen. We're then going to proceed once the erythrocyte has loaded on the oxygen in the lungs. It's then going to move via the pulmonary veins and then go back to the heart via the left atrium. It's then going to pass through the mitral valve, enter the left ventricle, and then the erythrocyte's going to leave the heart through the largest aorta in the body or through the aortic valve into the aorta. There it's going to be distributed to the rest of the body to feed oxygen, like I said, and perfuse the vital organs. And then that whole process starts over again. Remember, the human circulatory system is a closed system. That's what's important to remember. And that's especially important when it comes to hemostasis, all right? Because obviously Blood does not help our patients very much when it's on the outside of the patient. So our job as pre-hospital care providers is to make sure as much of that blood as possible stays inside the patient. Now, when we discuss the concept of hemostasis, we need to remember that there's two main components to hemostasis, all right? We have a cellular component consisting of platelets or thrombocytes, which is going to form a sticky plug at the injury site and help staunch or stop or at least minimize the amount of blood loss or hemorrhage. The second part of hemostasis is the clotting cascade, which consists of proteins and enzymes. It's a chemical reaction that's going to help form or strengthen that clot and therefore help the process of hemostasis and stabilize that process. Now, there's three main steps or components to hemostasis. The first is you're actually going to have vasoconstriction. All right, the blood vessels, when you have an injury to a blood vessel, that vessel that's damaged is automatically going to constrict or get smaller. And that obviously is going to help minimize or slow down the hemorrhage. And that's one of the reasons why, really interesting, you're like, why does this matter? Well, it matters because there are certain types of injuries where this initial act of hemostasis doesn't work as well, all right? And so typically what we see with crush injuries, injuries where the blood vessel or that extremity is mangled, such as example with crush injuries, or in the military setting, you have explosions, you have shrapnel, fragmentation, improvised explosive devices. And whenever you have that crush or mangle injury or an avulsion type injury where that blood vessel is severely damaged, it's not going to be able to vasoconstrict as well. And that's obviously going to result in greater hemorrhage. Therefore, those are the types of injuries, as opposed to like a clean, laceration or incision where the blood vessel will be able to vasoconstrict. Those other types of injuries tend to be the ones where we are going to need to use tourniquets, okay? All right, so that was the first part of hemostasis, or vasoconstriction, where the blood vessel gets smaller and therefore helps minimize the amount of hemorrhage or blood loss. Next, step 2 is platelet aggregation, or thrombocytes, okay? That's where all of our platelets come together and act as a sticky plug to form a clot. And coupled with that, all right, you do have proteins like von Willebrand's factor that help those platelets stick together. All right, they help stabilize that clot. And then we have our third and final step in the hemostatic process, where you have the clotting cascade really kick in. And remember, we have 13 different clotting factors, all right, and they're all various proteins and enzymes that actually work together in synergy, all right, to help stabilize that clot and make it more effective and ensure that it lasts long enough that actually hemostasis will occur. Now, it should be noted with the clotting cascade, with all those proteins and enzymes, some of the important ones, all right, we have the protein thrombin. And the reason why thrombin is important is that thrombin converts the inactive form of fibrin, okay, which is called fibrinogen. It takes that inactive form and then converts it into the active form, which is fibrin. And the active form, fibrin, is actually what develops or creates that fibrin mesh, which stabilizes the blood clot, all right? And that ultimately is what stops the hemorrhage and the blood loss. So the clotting cascade, and particularly thrombin, is of critical importance when we're talking about hemostasis. So remember, all right, you have fibrinogen, which is the inactive version, is converted into the active version, or fibrin, which then forms that stabilizing fibrin mesh, which stabilizes the clot and makes it a permanent structure there. So it can't be dissolved, it can't be broken down easily. And that's going to come into play later when we talk about various therapeutic modalities for controlling hemorrhage. Now, realize that there's various types of injuries, okay? And we're going to talk about there's actually a clinical importance or relevance as to why you need to know about these different types of injuries, all right, that result in hemorrhage or bleeding. All right, first we can break down injuries into open wounds or closed wounds, or internal versus external, all right? Now, external wounds or open wounds are ones that we can see and that the skin, all right, the integrity of the skin is compromised or broken, all right? Those are injuries, typically we see with like lacerations in the field, amputations, etc. Those are ones we can typically not only treat in the field, but we do have the added complication. Don't forget, and this is why knowing these different injury patterns are important. If you have an open wound where the skin's compromised, all right, you do run the risk of infection, all right? And because remember, our skin is our primary protection, our initial frontline protection against various pathogens in the environment, bacteria, for example. Right? And that's why knowing if you have an open wound versus a closed wound is important. Then we have internal hemorrhage, all right, where you can still have hemorrhage, but the integrity of the skin isn't broken, all right? And so that's internal bleeding or a closed wound. Now, the advantage of that is that you typically don't have to worry about infections, but we have the added complication as EMS providers in that sometimes our ability to treat that in the field, in the pre-hospital care setting, is limited, all right? And so ultimately, if you have patients with, internal hemorrhages, hematomas, bleeding into a body cavity, such as the pelvis with a pelvic fracture, for example, those type of injuries ultimately are only going to be fixed by a trauma surgeon. They're fixed by cold steel, people, all right? They need surgery. And so we are just going to, try to stabilize the patient and keep them going long enough until we can get them to definitive care, i.e. a trauma center. Now, in addition to those types of categories, you can also categorize bleeding by the type of injury. You have lacerations versus avulsions versus amputations versus incisions or abrasions, all right? And that's the type of injury. In addition, you can also categorize hemorrhage and bleeding, whether based on the blood vessel that's actually damaged. And so you have arterial versus venous bleeding. Obviously, arterial bleeding is the more serious. It tends to be the more life-threatening versus venous bleeding, which can still be serious, but usually is not as life-threatening or critical as arterial bleeding. How do you differentiate between the two? All right. Arterial bleeding tends to be the bright red bleeding that's spurting across the room. All right. When the unsuspecting brand new EMT takes that trauma dressing off and it hits him in the face and flies like 5 feet across the room. That bright red blood that's spurting, that's arterial bleeding. Versus venous bleeding, which tends to be darker in color because it's deoxygenated and it tends to flow. All right. So you don't have that spurting characteristic to it. Typically, that's the difference between your arterial hemorrhage versus your venous hemorrhage. And then you can also finally categorize our injuries and our hemorrhage via the location. All right. Now you're like, why do I care about the location of the bleeding? Well, we care about the location of the bleeding because some of our treatments or our therapeutic modalities, such as tourniquets, all right, we have limited application based on the location. So if, for example, if you have an extremity injury on a leg, arm, etc., and it's severe, it's a critical life-threatening injury, it's arterial bleeding, the patient runs a risk of exsanguinating, all right, we can use a tourniquet to help control that if it's on an extremity, obviously. Now, we run into difficulty when we have like junctional wounds, all right, in the axilla, in the groin, the inguinal region. Sometimes where the wound is located limits our treatment options.
So for instance, if you have an axillary wound or another type of junctional wound, such as in the inguinal region or the groin, and it's physically impossible to apply a tourniquet, then we have to resort to other treatment modalities such as hemostatic agents, packing the wound, etc. So the location of the wound can prove critical as far as our treatment options go. And so just remember that. Now, talking about the pathophysiology of shock. Remember, when we use the terms physiology versus pathophysiology, we're talking about physiology is the normal functioning of the body. All right. Pathophysiology is when that functioning of the body is altered, usually in a negative sense, all right, due to either injury, trauma, or illness, all right, disease factors. And anatomy, by definition, is the structure or, the anatomical components of the body. All right. And remember, anatomy affects the physiology. All right. Or the structure of that organ or tissue affects the function of the tissue. Form affects function. All right. Now, to tell you how the physiology or the pathophysiology of shock works and why it's important, all right, we have to talk about blood volume. And we're going to use some generalities here, but in general, the average adult human being, all right, Homo sapien, all right, our species, has ultimately about roughly 5 liters of blood. Males tend to have a little bit more blood than the average female due to our size, but in general, the average adult has about 5 liters of blood. Now, you might be like, why do I care about that? Well, it's important when we're talking about the pathophysiology of shock, or how shock, all right, affects the normal functioning of the body, specifically the circulatory system. And to give you some examples, all right, let's first talk about, hemorrhage or blood loss and how it's divided into 4 classes, going from minor injuries, minor hemorrhage, to severe, critical, life-threatening hemorrhage. All right, so we have 4 main categories. First category, class 1, usually accounts for 15% blood loss or less than a liter of blood, all right, less than 750 milliliters. Class 2, all right, accounts for 15 to 30%, and that can be anywhere from 750 milliliters to 1.5 liters or 1,500 milliliters. All right, and that's moderate hemorrhage. Then you start getting into the severe and life-threatening classes of hemorrhage. Class 3, all right, accounts for 30 to 40% of hemorrhage, and that's 1.5 liters to 2 liters of blood, or 1,500 to 2,000 milliliters. All right, and that is severe. That's a severe class of shock. All right, and then finally, we have the life-threatening critical class of shock, class 4. All right, which accounts for greater than or equal to 40% of our total blood volume, or greater than 2 liters of blood. That's 2 IV bags of blood, people. That is a lot of hemorrhage. Now, you're like, I can't picture this in my mind. How do I, how do I figure this out? Well, realize that if you have a closed femur fracture, you can lose up to 1.5 liters of blood in your femur, in the tissues in your femur. All right. And so theoretically, all right, just a femur fracture by itself as an injury can cause up to a class 3 bleed, all right, or roughly up to 30 to 40% of your total blood volume. That is a potentially life-threatening injury. And then we get into other injuries, such as a pelvic fracture or a pelvic injury that results in hemorrhage into your pelvic cavity. And that can result in a blood loss of 4 to 6 liters of blood. And if you look, we just said that the average human only has about 5 to 5.5 liters of blood. And if you can lose 4 to 6 into your pelvis, guess what? That's your whole blood volume. You can actually hemorrhage into your pelvic cavity. All right. So you can actually exsanguinate, all right, or suffer total blood loss, i.e., decompensated shock, massive hemorrhage, i.e. death, all right, from hemorrhaging or bleeding into your pelvic cavity. All right. So that's why knowing the pathophysiology of shock is so important. Now, so that's going to cause the problems. And remember, when we're dealing with the pathophysiology of shock, remember shock, and there's lots of different kinds of shock. All right, there's lots of different causes of shock, but ultimately the end result is the same. The pathophysiology is the same. It's the inadequate perfusion to our vital organs, and that's what's going to kill you, or that's what's going to kill your patients. All right. Now, how do we as EMTs and paramedics try to prevent this? All right. How do we try to help our patients? And we're going to do that via these techniques here. So we have direct pressure, all right? Simple, basic, tried and true. It's effective in the vast majority of our injuries, which involve hemorrhage, all right? Then we have the up and coming techniques such as tourniquets, and we're going to talk about tourniquets and the history of tourniquets and why tourniquets work, how tourniquets work, when we started using them and the whole process involved with tourniquets and the implications for using tourniquets. And then we're going to move on to occlusive dressings or chest seals, all right, dealing with chest injuries to the respiratory system, to your lungs that can, help prevent tension pneumothoraxes. And then we're going to move on to wound packing, and remember what I said before, using that wound packing technique, we can often use that in situations where we're dealing with injuries from an anatomic standpoint, such as junctional wounds in the axilla or the inguinal regions, where we can't use tourniquets, and therefore we have to pack the wound to try to control that hemorrhage. And then finally, but not least important, we're going to talk about the various hemostatic agents and how they work, why they work, and the advantages and disadvantages of using them, all right, and their role in controlling hemorrhage in the pre-hospital care setting. Now, our first line of treatment for controlling all hemorrhage, all right, I don't care what type of hemorrhage it is, this should be your go-to. Your first line of treatment should be direct pressure. All right, it's the most common method for bleeding control, and it works in the vast majority of cases. All right, typically it's best at controlling hemorrhage, which is mild or moderate in severity. All right, and when I say apply direct pressure, so everybody look at that top picture. That is not the type of direct pressure you want to use. When I mean direct pressure, you're using two hands leaning on that wound with all of your weight. All right, if you need to, and it's appropriate, and you need your hands to, provide other treatment, you can actually put your knee into it, okay? Step on the wound, lean on the wound, kneel on the wound, all right? Whatever you need to do to apply that direct pressure. But typically, we're going to apply it with two hands, all right, and lean on it with all of your weight, just like you were doing CPR. That's the best way to apply direct pressure. Our next treatment modality we're going to talk about is the use of tourniquets. And, just some cool factoids and a little bit of history about tourniquets. All right. The actual first recorded use of tourniquets in medical literature was from 600 BC in India. All right. That's pretty cool. Now, the modern use of tourniquets, what we would typically think of as tourniquets, occurred in 1674 at the Battle of Flanders. Tourniquets were improved during the Civil War. They were improved and used more extensively during the World Wars, specifically World War I and then World War II. All right. And then for various reasons, they kind of fell out of favor, especially in the civilian side, with first aid and EMS care providers. Now, that changed, okay, during the global war on terror, because what we found was, unfortunately, warfare is a great way to improve your trauma medicine. All right. And what they found during the global war on terror after 9/11 in both Iraq and Afghanistan is that tourniquets save lives. Without a doubt, the research is rock solid. All right. It's been proven. tourniquets, if you have an extremity injury, can save a life. Without a doubt, hands down, definitely works. There's no doubt about it whatsoever. All right. So therefore, tourniquets became mainstream and in the military, and then eventually they were adopted on the civilian side of the house too, for civilian EMTs and paramedics dealing with trauma patients in the pre-hospital care setting. And if you look at it, if you look at that final bullet point there on the slide, it's important because what we found was that during the war on terror, all right, from Iraq and Afghanistan, they showed that the fatalities from extremity injuries after we implemented the widespread common use of tourniquets dropped from almost, just under 8%, 7.8%, all the way down to 2.6%. That is a statistically significant drop. That is a lot of lives that were saved due to the use of tourniquets. Okay. And remember, here's the basic steps for tourniquets. So they've done some interesting studies, and what they found was, all right, they did this really cool study where they had a group of civilians and they trained them on a particular tourniquet, all right, an application of a particular tourniquet. And then they went on to try to have those civilians replicate that tourniquet application with other types, other brands of tourniquets. And they found that skill or training in applying tourniquets was not readily transferable between different types of tourniquets. So what does that tell us as EMS professionals, as EMTs and paramedics? It tells us that we need to train on the particular brand or type of commercial tourniquet that you have for your service. All right. You need to practice. You need to be familiar with it. All right. And you need to know how to use it. So that's one critical point to remember. The second critical point to remember, there was a study done in 2017 with law enforcement personnel, all right, so police, that showed that they compared the success rate for using improvised versus commercial tourniquets. So hasty tourniquets, ones where, you had to improvise, come up with field expedient materials to try to fashion a tourniquet, all right, such as strips of cloth, clothing, towels, etc., with various bars or pieces of wood, etc., that you used as a windlass, and compared that to the commercial ready-made tourniquets. And what they found was the quality and success rate for commercial tourniquets vastly exceeded the improvised tourniquets. All right, the improvised tourniquets failed 6 to 7 times at the rate compared to the commercial tourniquets. And there's been similar studies from Afghanistan on the military side of the house that actually confirm that. So what does that tell us in the pre-hospital care setting? As EMS providers, as professionals, we should be using commercial tourniquets, people. Remember that. Okay, so how do we apply a tourniquet? All right, if it comes down to the point where we have critical hemorrhage and we need to control it and direct pressure was not sufficient to control that hemorrhage, then you're going to identify the bleeding site and, if possible, expose that site. Next, all right, while you're applying the tourniquet and you're deploying it, you want to have somebody, either yourself or another provider or even a bystander, if you need to, apply and direct, hold that direct pressure while you're applying the tourniquet. That's critical. And that's, like I said, if you need to, and it's an extremity injury and you're applying the tourniquet and you need your hands to, it's just you, all right, you can kneel on the wound, okay? Literally put your knee into it, all right? However you need to apply that direct pressure, do so, all right? Step 3 is you're going to wrap the tourniquet around the extremity, either arm or leg, 2 to 3 inches above the injury site, all right? That's critical. You want your tourniquet application to be 2 or 3 inches above the injury site. However, you want to make sure you don't apply the tourniquet directly on top of a wound, a fracture, or a joint, all right? So typically you're going to apply that tourniquet 2 to 3 inches above the injury site. However, you may need to adjust that if you run into the complication where putting it 2 to 3 inches above the injury site would place it directly on a wound, a fracture, or a joint. All right, so then you just need to adjust accordingly. Step 4, you're going to pull the tourniquet strap as tight as you can. And that's usually considered to be one of the critical failing points or mistakes that people make when they're applying tourniquets. They don't get that tourniquet strap tight enough. You really need to crank on it, get it as tight as possible, because that's going to make securing, twisting the windlass and actually getting complete hemorrhage control much, much easier. All right. So step 4 again is you're going to pull that tourniquet strap as tight as you can, crank it down, and then secure it. Step 5, you're going to twist the windlass or the bar until that bright red bleeding stops. That's critical, and you want to stop all hemorrhage. When you apply a tourniquet, there should be nothing bleeding from that injury site. All bleeding stops. All right, 100%. Step 6, you're going to secure the windlass to prevent it from unwinding. Usually there's a clip, a bar, all right, some other device to secure that windlass to make sure you don't have a catastrophic failure and that tourniquet loosens up and you blow your clot and you end up having potential for life-threatening hemorrhage again. And remember, that is a good example of why you need to train with your specific tourniquet, because different commercial brands of tourniquet have different ways to secure the windlass. The final step, step 7, is you need to document the time. All right. You need to write it either on the patient, you need to write it on your documentation, you need to write it on the tourniquet. For example, several tourniquet types have a place for you to write the tourniquet, all right, with a Sharpie or a pen, whatever, all right, on the actual tourniquet itself. For instance, the CAT tourniquet or the combat application tourniquet actually has a little strap that you can use to help secure the windlass, and it's white, so you can actually document the tourniquet application time on that. Now, you might ask, why do I care about when I applied the tourniquet? Well, you care because if you roll into the trauma center and you don't know when you applied that tourniquet, you will get the beat down from the trauma surgeon. All right, bad things will happen to you. And the reason why the time of the application of the tourniquet is so important, that's going to affect their surgical options and their surgical approach when dealing with that injury, from a surgical standpoint at the trauma center. All right. Typically, we have 4 to 6 hours to salvage limbs after a tourniquet is applied. Now, again, our research from the Global War on Terror has proven, all right, that if we have young, healthy patients that don't have a lot of atherosclerosis, all right, that 4 to 6 hour time frame or window can be extended. But just realize that the longer you go, all right, after tourniquet application, realize that trying to salvage that limb potentially has a lot more complications that the surgeon and the medical team will have to deal with the longer that tourniquet is applied. All right, so those are the basic 7 steps. Now, some points to keep in mind. All right, once you apply a tourniquet, and obviously you always want to follow your local protocols, but in general, once you apply a tourniquet in the pre-hospital care setting, we never, ever, 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 never, 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 ever, ever, never, never take that tourniquet off. All right. Bad things will happen, like massive exsanguinating hemorrhage, if you go and take tourniquets off. All right. In general. In addition, you do have the option, if you cannot, for whatever reason, control the hemorrhage completely, 100% with your initial tourniquet application, you can apply, it is acceptable to apply a second tourniquet proximal or just above, all right, the first tourniquet on that extremity. All right, they should be touching each other, but that second tourniquet can be applied just proximal to the first tourniquet to help control massive hemorrhage if the first tourniquet wasn't enough. All right, and then don't forget, you apply that tourniquet 2 to 3 inches above the injury site, except if it's that'll place it directly over a fracture, a wound, or a joint.
Moving on, we're going to talk about occlusive dressings or chest seals. Obviously, if you have an injury to the thoracic cavity, all right, or anywhere near the thoracic cavity, and that includes near the diaphragm, because if it is a projectile type injury, like a bullet wound, depending on the path of that projectile, you could have, the entry wound or the exit wound might enter in the abdomen. However, if the opposite wound, all right, can exit through the thoracic cavity. So you could actually have damage to the thoracic cavity and it might not be obvious. So in general, if you have wounds anywhere near the thoracic cavity or the diaphragm, all right, you want to apply occlusive dressings and or commercial chest seals, depending on what your protocols are and what's available to you. Now, the commercial chest seals, all right, for example, you have the chest seals such as the Asherman chest seal, you have the Hi-Fin, the Halo, or the SAM chest seal. Those are all different brands or options for commercial chest seals. You apply them, you follow the directions, and they tend to work really well. However, if you don't have that option, your service doesn't have the commercial chest seals, you can do a homemade improvised occlusive dressing, which will work, all right? And you use an airtight material, some type of plastic. You can use multiple layers of plastic wrap. You can use the outer bag or outer plastic cover from an IV bag, all right? But it has to be airtight and it has to be firm enough that it's not going to collapse into the wound, all right? With our occlusive dressings, if you're going to improvise one, all right, you're going to tape it or secure it on 3 sides, people, 3 sides. All right, look at that diagram there. Look at the top picture. All right, you secure it on 3 sides. And the purpose of that is to help prevent air from entering the chest cavity after a penetrating injury to the thorax and help prevent or minimize the potential for that lung collapsing and eventually a tension pneumothorax. Now, you leave the 4th side unsecure, untaped, to act as a valve, which will allow air to escape. So if you have air build up, all right, potentially you might need to burp the wound or briefly open it up or remove the tape on one side just to allow that excess buildup of air to escape. All right. Now, obviously, with all of these techniques and therapeutic modalities, you always want to follow your local protocols. But in general, remember, occlusive dressings, you seal on 3 sides, people. Wound packing, and again, this is a useful technique for dealing with those injuries that we have where we typically cannot use a tourniquet, such as either in the shoulder, the armpit, the axillary region, or the inguinal or the groin region, somewhere where we can't physically apply a tourniquet, or like in the neck, for instance, okay? Obviously, putting tourniquets on patients' necks, all right, is bad. That's contraindicated. Don't do that, all right? That would be no bueno, no good. All right, so wound packing. Notice that picture there. Notice how that medic is applying the wound packing. He's maintaining a occlusion or pressure on that damaged blood vessel in the wound. He found the blood vessel that's bleeding. He's applying direct pressure on it. And then he's basically stuffing his wound packing into the wound, feeding it in. All right, feeding it in. And again, all right, that it's used where we cannot place a tourniquet. All right. And you can use any type of roller gauze or packing gauze. And when you apply that, you apply it until it's tightly packed. That whole cavity, the whole wound site should be filled to the brim, to the surface of the patient's body with that gauze, with that roller gauze. All right. Now, there are versions of gauze that have hemostatic agents built into them. All right. And those type of hemostatic agents or the wound packing materials tend to work better. All right. Because not only do you have the direct pressure that's placed on that injured blood vessel, all right, to help control hemorrhage or bleeding with direct pressure,
but you have the chemical reaction, which helps promote the actual blood clot formation with the hemostatic agent at that site. So they'll work in synergy, or they'll work together to better help control that life-threatening hemorrhage. All right. Then we have our hemostatic agents, all right? There's two types of hemostatic agents. We have the active agent, which promote the formation of clots, and then we have the passive agents, which increase the volume, all right, and therefore help stop the bleeding through direct pressure, because it's going to absorb blood. And that absorption of blood is going to increase the volume of that packing material, and therefore put direct pressure on the wound. Now, there's two general types of hemostatic agents. You have a powder type, and then you also have gauze, which is impregnated with the hemostatic agent. All right. Typically speaking, what they found, the research we've done since 9/11 has shown that the impregnated gauze tends to have superior hemorrhage control qualities compared to the powder version. They've done some studies comparing the two, and what trauma surgeons have typically found is that in some cases, the granular powder tends to be, unless you remove all of the hemorrhage, when you apply the powder, it can get lost in the actual volume of blood and not actually get down to the actual wound site where it can actually work to help control the hemorrhage. So in general, the latest research has shown that the impregnated gauze tends to be the superior version of the two types of hemostatic agents. All right. Then we have TXA, or tranexamic acid. This is a fantastic hemostatic control agent. All right, it's an intravenous medication that's used to treat life-threatening uncontrolled hemorrhage. And as a cool factoid, little bit of history, TXA, or tranexamic acid, was originally developed to control severe bleeding, menstrual bleeding in women. All right. And then it was adopted for the use in trauma care, in trauma medicine. Specifically, it started out usually in the military side of the house, and then subsequently it's been adopted by the civilian side as well. Now, from a pharmacology standpoint, the mode of action of TXA, it doesn't directly stop bleeding, but what it does is it indirectly helps stop hemorrhage and helps promote hemorrhage control, or hemostasis, by stabilizing blood clots and preventing them from being broken down. So you end up achieving better hemostasis that way after administration of TXA. And the way TXA works is that it actually inhibits the activation of the blood protein plasminogen. All right. So plasminogen in its active form, which is plasmin, is responsible for the breakdown of the fibrin mesh, which helps stabilize blood clots. So TXA helps prevent that process by preventing the inactive form of that protein plasminogen, prevents it from being activated, and therefore helps stabilize blood clots and prevents them from being broken down. That's how TXA works. All right, just as a note, obviously, again, you need to follow your local protocols, but typically speaking, a standard dose, you would do a initial slow IV push, all right, of 1 gram of TXA, diluted in a bag of saline over 10 minutes. And then you would follow that with a maintenance infusion of 1 gram over 8 hours. And obviously that would be continued at the trauma center. But the key point to remember is you're going to start with a slow IV push, all right, over 10 minutes, and then you're going to hang a drip, all right, to maintain that blood level of TXA. Now, realize that there's different options for volume replacement or treating these patients in the field. Now, gone are the days of Roy and Johnny, people. All right, we shouldn't be doing the old school 1970s treatment where we basically hung 2 large bore IVs and just left them wide open. All right, we do not want to have our patients bleeding out because we raised their blood pressure to the point that we blew their clots off and now they're bleeding out. They've bled out all of their erythrocytes, all their oxygen carrying capacity, and all their thrombocytes. That's bad. That's no bueno. Don't do that. All right. So current trauma medicine, therapy, the protocols tend to promote the use of permissive hypotension. All right. And what I mean by that is, so you want to maintain their blood pressure at a level where you can actually maintain perfusion of their vital organs, heart, brain, kidneys, etc. All right. So you don't end up in organ failure and you don't end up in decompensated shock and you keep your patient alive. However, you don't want to raise that blood pressure so much that you exsanguinate them. All right. So again, permissive hypotension, which typically, again, follow your local protocols. All right, but most protocols indicate that it's going to be a systolic blood pressure of roughly 90. All right, give or take. Now, obviously, okay, most of our EMS services, all right, our primary go-to for volume replacement is going to be a type of crystalloid isotonic IV fluid, such as Plasmolite, Norma Solar, lactated ringers, all right, normal saline. Follow your local protocols, use the type of fluid that your system recommends. However, most systems are going to use isotonic crystalloid fluids. They're good for maintaining that permissive hypotension. However, the problem is they don't have any oxygen carrying capacity and they don't carry, platelets for, helping, or any of the clotting factors for helping control, hemorrhage and promote hemostasis. However, we do have some specialized services such as air ambulances, various military units, especially aeromedical evacuation units that actually do carry blood products. And some of our more progressive EMS systems will carry blood products. Obviously, they have specialized requirements. They need to be refrigerated. They have a limited shelf life, etc. But those are the ideal volume replacement because they do have erythrocytes, they do have an oxygen carrying capacity. All right. And, depending on the type of blood product you have, they can also have clotting factors and platelets, which will help promote hemostasis. Now, remember, the ultimate treatment for most trauma patients is not going to be in the pre-hospital care setting, all right? Our goal is to get them to definitive care. And that definitive care, all right, by definition, in most cases, is some level of trauma center, all right? The higher level trauma center, the better, generally speaking. The research is out there. It's rock solid. It's been proven. All right, trauma patients, critically injured trauma patients that go to a level 1 or level 2 trauma center have a much better prognosis than those that go to a level 3 or a regular community hospital. All right. So obviously the highest level trauma center you can get that patient to, all right, for definitive care will provide the best prognosis for that patient. All right. Now, follow your local protocols. If you're in an extremely rural area and you don't have a trauma center near you, all right, you may need to transport to a local community hospital, have them stabilized, and then flown out, or directly fly them out from the scene via aeromedical service, via helicopter, for example. All right, but you need to follow your local protocols. But in general, all right, the critically injured hemorrhagic shock patients, especially those that have, severe hemorrhage, the class 3, class 4 hemorrhage patients we talked about, those patients definitely need a trauma center. So our role as EMS providers is to provide diesel treatment, all right, get them there as soon as possible in a safe, effective, and efficient manner, and to make sure they get that trauma surgeon, the cold hard steel, where they can, repair and perform hemostasis and stabilize those patients. All right. So, in conclusion, our first section there, remember, as a review, hemorrhagic shock can be life-threatening. Hemorrhagic shock, all right, shock is defined as inadequate perfusion to our vital organs, all right? And remember, we need that perfusion or the provision of adequate blood flow, which will provide oxygen and other nutrients and removal of other waste products such as carbon dioxide and lactic acid to maintain, proper homeostasis, all right, or continued functioning for our patients. Don't forget our ultimate treatments, all right, direct pressure, 2 hands, as much pressure as you can, tourniquets if we have an extremity injury, 2 to 3 inches above the wound site, all right. You turn the windlass until the bright red bleeding stops. All bleeding should stop. All right, don't forget that. And you can use your hemostatic agents in addition to or instead of, if you have junctional injuries, all right, you can use hemostatic agents and pack the wound, all right, with gauze. You can also use tranexamic acid or TXA to help control bleeding. And then don't forget, those patients need to get to a trauma center. However you do that, I don't care, but they eventually need to get to a trauma center. All right, moving on. Our next topic is going to be intravenous therapy for pre-hospital care providers. We have 4 main objectives here. First objective is to recognize universal precautions and body substance isolation procedures when performing IV therapy. Second, we're going to describe how to actually perform IV cannulation or insert an IV using anatomic landmarks. Then we're going to, objective 3 is we're going to differentiate among different types of IV solutions and cannulation devices, different types of IVs, all right, for the management of both trauma and medical emergencies. And then finally, our 4th objective is to identify potential complications of IV therapy. Because remember, it's a good therapeutic modality, all right? We can use IV therapy to help our patients, both trauma and medical patients, but it's not a benign treatment, okay? Bad things can happen, and we need to be aware of those and do what we can to help mitigate those problems or prevent them from ever occurring. Okay, so typically, why do we start IVs, people? All right, we start IVs not just because you need to check the box and meet your quota for the period. All right, we start IVs for a medical reason. All right, typically you either need volume replacement if it's a trauma patient and they have hemorrhage, and or you have a medical patient that's dehydrated, and so therefore they need fluid replacement, they need volume replacement. And or you might have a need to administer medication, all right? Those are the patients we typically start IVs on in the pre-hospital care setting. Now, remember, okay, patients are icky, all right? They have stuff you don't want, various pathogens, bacteria, viruses, all right, etc. Remember, you are number one, people, all right? You are number one. And remember, even if you don't care about yourself, you don't want to take something home to your family, your friends, your loved ones. All right. So therefore, when you do IV therapy, you need to practice universal precautions and make sure you take body substance isolation precautions. So make sure you wear your PPE, your personal protective equipment. Make sure you're wearing eye protection. Make sure you're wearing gloves. All right. And then wash your hands after the call, people. All right. According to the CDC, the simple act of washing your hands is the most effective way to prevent disease transmission. Simple as that, people. Wash your hands. And if you don't have access to running water, all right, the alcohol-based gels, they're not as effective, but they're better than nothing, and they're a good alternative. So what are we talking about when we mention the term universal precautions? All right. By definition, universal precautions are protective measures developed by the CDC or Centers for Disease Control for use of dealing with objects with blood, body fluids, or other potential risk of communicable or infectious diseases. All right, that's the fancy medical definition. The way I like to look at it is, okay, for us firefighters who need simple definitions, simple words, monosyllabic words. All right, universal precautions means you need to treat any body fluid, all right, anything that's wet and sticky that's not yours, as a potential source of infection. Blood, all right, synovial fluid, cerebrospinal fluid. I don't care. If it comes out of another human being and it's wet and sticky and it's not yours, make sure you don't either A, you don't touch it, or B, you actually have your PPE on. All right. And then by definition, body substance isolation, or BSI, consists of a whole set of infection control practices that reduce or minimize the opportunity for exposure of EMS providers in the daily care of patients. All right. So what they're basically saying is, if you practice BSI, or body substance isolation protocols, that's going to minimize the chances that you're going to be exposed to anything that might expose you to a pathogen that could infect you, bacteria, virus, etc. Again, if it's a body fluid and it's not yours, you shouldn't be touching it, people. Now, remember, we all know there is nothing sterile in the pre-hospital care setting, all right? Sterility means the absence of all life. That's obviously not practical or achievable in the pre-hospital care setting, all right? We all know the world is gross and dirty and disgusting. However, all right, when we practice IV therapy, when you're inserting an IV, people, you do need to be at least aseptic, all right? You need to be clean. All right, you need to follow some basic common sense protocols, all right, that'll help minimize any potential complications from IV therapy. So what do I mean by that? From a practical standpoint, one, make sure you wash your hands and you're wearing PPE, because not only are patients icky, but you could be icky, all right, and you don't want to give whatever you have to your patient. Remember, in addition to our normal medical and trauma patients, we do have patients that are immune compromised. Either they're cancer patients that are receiving chemotherapeutic agents. We have patients that are organ recipients and they're on immunosuppressive drugs. All right, we have patients that have that are suffering from immunosuppressive diseases. For example, patients that have AIDS due to the HIV or the human immunodeficiency virus. All right, all those patients are potential at higher risk for infectious diseases, and we need to try to keep them safe. So the way we do that is wash our hands, wear our PPE, all right, and then make sure we disinfect our IV insertion site as best as possible. Follow your local protocols, all right, and use whatever appropriate disinfectant you have, either chlorhexidine, povidone iodine, isopropyl alcohol, 70% or better, all right? And make sure you disinfect that site. When possible, you want to go for the arms, the upper extremities, or if you have a critical patient, all right, you could always use the external jugular vein, all right, whatever vein would be appropriate, and follow your local protocols. But upper extremities are better than lower extremities. Why, do you ask? All right. So why should we not use, obviously, if you need to, and you need to get, IV access, you can use any vein you want in the body. All right. As long as you're following your local protocols and common medical practice. However, the reason why we want to try to avoid inserting IVs in the lower extremities, the legs, the feet, etc., all right, is that those sites, it's been proven, all right, the research has shown that those IV sites are much more prone to other complications, including phlebitis, secondary infections, etc. Right? Now, realize that there's four major routes for infections, people. 4 major routes for infections. One, your catheter or the hub of the IV, the plastic component, can actually be contaminated directly by touching something or by body fluids. All right. And again, that's why we want to wear PPE and be aseptic when we're doing IV therapy. The second major route of infection is the catheter itself may actually act as a bacterial colonization point or you may have contamination and the bacteria may reside and then multiply there, all right, in the actual catheter that's been inserted into the vein. Third, the third major route of infection is the IV fluids may be contaminated, all right? Again, make sure you need to check your IV fluids before you hang that bag, all right, and hook it up to your IV catheter. So how do you know you're given the correct and a safe bag of IV fluids? All right, there's a couple things you need to check. First, one, all right, make sure it's the correct IV fluids. Make sure you're hanging what you want to hang. Look at the name or the label, all right, on that IV bag. Second, make sure that IV fluid is clear. All right, there should be no chunkies or floaties, people. No chunkies or floaties in your IV bag. That's bad. That's no bueno. It means it's contaminated. All right, don't use it. Dump it. Also, all right, third, make sure your IV bag is in date. It's not expired. Check the expiration date. That's important. So again, make sure you're hanging the correct IV fluids. Make sure there's no chunkies or floaties, and then check the expiration date. Once you've checked all that, the IV bag should be good to go. The fourth major route of infection is you can get environmental factors, all right? The environment we work in, either at an industrial accident site, a motor vehicle crash, all right, or just out in on a farm somewhere. We all know there's dirt, there's contamination, all right? Things are not clean, all right, on the vast majority of our 911 calls, all right? So just, realize that. Again, that's why we disinfect our sites. That's why we wear PPE, all right? And we try to be as aseptic as possible when we're starting IVs. Sharps, people. All right. Don't be that medic. Don't be that guy. All right. Make sure you're using common sense and practicing, all right, practicing good infection control procedures when you're dealing with your sharps. Don't be that guy that gets their EMT stuck because you're a slob, all right? When you are done starting your IV, make sure you make that sharp safe, all right? If you have a safety model type IV catheter, all right, use the mechanical mechanism, make sure it's safe, make sure that the needle or the sharp is sheathed and it's safe, and or just stick the sharp directly in a sharps container. Make sure you have sharps containers anywhere you could start an IV. So not only in the back of your truck, but make sure you have a small sharps container with you in your first in bag, your jump kit. All right, make sure even if you're on scene, you're not leaving IV catheters lying around. Don't be that medic that's sticking them in the ground, sticking them in the bench seat, just leaving them out on the stretcher or with the patient. All right, don't get your patient stuck, or your other personnel stuck, your EMT stuck. All right. Everybody look at that fourth bullet point on the slide, the fourth bullet point. The CDC estimates that 62 to 88% of all sharps injuries could be prevented by using safer needles. All right. That is the vast majority of all sharps injuries could be prevented, people. That's the takeaway message right there. Now, follow your local protocols, all right, but these are the basic procedures for starting an IV, all right, inserting an IV cannula. Again, be aseptic, all right, wash your hands, all right, wear your PPE, all right, follow your BSI. Now, again, use upper extremities versus lower extremities whenever possible. Obviously, the specific circumstances of the call and the patient's injuries or illnesses may dictate otherwise, but in general, you want to pick an arm versus a leg. All right. And again, just use common sense, people. Make sure you have all your gear, all your equipment, your tape, your tourniquet, your gauze, your IV catheter, all right, your INT, your IV line, your bag, all of that set up, ready to go, and within arm's reach before you start your IV. Don't be that medic that you're halfway through the procedure, you got the IV in, and now you're like, oh, I don't have any gauze, or I don't have the IV bag ready. All right, don't be that medic. Make sure you have everything ready within arm's reach where you can get to it before you start the procedure. Okay. All right, we have various type catheters. Remember, the commonly used ones are anywhere from 14 gauge all the way up to 24 gauge. The smaller the number, the bigger the diameter, okay, or the internal diameter of that catheter that it is. All right. So, for instance, we have a 14 gauge catheter is going to have a much larger internal diameter than a 24 gauge catheter. Typically speaking, we use 14, 16, 18 gauges for our adult patients and for our trauma patients. All right. If you have a medical patient, especially a little old lady or something with awful veins, you may want to go 20, 22 gauge. All right. Even a 24 gauge in rare circumstances. And then for our pediatric patients, especially our neonates, our infants, you may want to go with a 22 gauge or a 24 gauge. And also remember, the reason we like our larger bore catheters and our shorter catheters is that you get greater fluid volume, our flow of fluids through shorter catheters and bigger diameter or bigger gauge catheters. So a 14 or 16 gauge catheter can flow significantly more fluid than a 22 gauge or a 24 gauge. All right? Don't expect you to memorize this, but this just illustrates the point and the differences in flow rates for various catheters. Again, 14, 16 gauges can flow a lot more fluids or a lot more milliliters per minute than our smaller catheters, such as the 22 and 24 gauges. All right, this is like a review, people. This is like EMS 101. Our IV fluids, again, you need to follow your local protocols, use whatever crystalloid, isotonic IV fluid that's appropriate for your patient and that follows your local protocols. Again, make sure that it is safe to use and it's the proper fluid. So you need to double check things before you hang that bag. Make sure it's the correct type of fluid. All right, Normosolar versus normal saline, 0.9% sodium chloride, for example. Make sure that it's clear, no chunkies or floaties. And then finally, make sure that it's not expired. Right? And again, whenever we're setting up IV bags, make sure that you're actually aseptic. People don't go licking or touching any of the ports or the components of the IV tubing or the IV bag that's going to go into the patient or, that you want to keep as aseptic as possible. All right. We all know how to hang an IV bag, people. All right. That's like EMS 101. All right. If you don't know how to hang an IV bag, I'm going to take your patch away. All right. But just as a review, here are the basic steps for setting up a administration set. All right. And the key points to remember are that you want to be aseptic about this. All right. Ideally, you should be wearing gloves when you're doing this. All right. Make sure that you have the drip chamber partially filled. All right. Make sure that you have the IV fluid run all the way through the IV line before you hook that up to the patient. All right, finding the correct vein. All right, you can use any vein in the body as long as you're following commonly accepted medical procedures and you're following your locals and or state EMS agencies protocols. All right. Typically, though, again, don't forget, use upper extremity versus lower extremity. All right. In critical life-threatening situations, you can, as long as your protocols allow it, you can even use the external jugular vein. Typically for our trauma patients, you want to use a large vein. So you can use the anacubital veins, all right, near the elbow. And or remember, if it's a medical patient, all right, and you don't need the large bore IVs, you can use any vein in the upper extremity. All right. Now, remember, IV therapy, it's a useful, practical, very effective treatment modality. It helps both trauma and medical patients. However, realize that it is not a benign procedure. Bad stuff can happen. You can hurt your patient by starting an IV on them. All right. So there are potential complications that we need to be aware of. And the reason you need to be aware of them is that if you know what they are, you can therefore potentially minimize the threat to them from ever occurring in the first place, or if they do occur, you can help mitigate the severity of the injury secondary to that IV complication. Okay, so again, we talked about the basic rules. You need to be aseptic, wear your PPE, follow BSI. All right, double check your fluids, make sure you're not giving, chunkies or floaties to your patient. That's important. All right. But realize that, you do have potential complications such as hematoma formation if you blow the vein. All right. That accumulation of blood can actually put pressure on and damage, various tissues in the body, such as nerves. It could also cause a compression injury, such as compartment syndrome. All right. If you end up having a catheter shear, all right, you can end up having an embolus in your patient's circulatory system. That's bad. All right. That's why we never take the catheter, all right, and pull it off the needle and then reinsert it. All right. That's bad. That's no bueno. That's how you end up with chunks of plastic in your patient's circulatory system, or catheter shear. That's bad news. Some other complications, okay? If you end up with, unfortunately, we've seen, sometimes our patients have poor vasculature. They're hypotensive, or due to chronic concurrent medical conditions, that trying to find a acceptable vein can be difficult. And if you end up, doing the hunt and peck method, searching around, all right, you can actually cause vein irritation or phlebitis, or inflammation of the veins. And that can result in pain, bleeding, potential nerve damage, etc. You can also damage ligaments and tendons, all right, when you inadvertently hit them as you're trying to start an IV. All right, you can cause nerve damage by inadvertently hitting the nerve, or causing, hemorrhage or a hematoma to form at a site where a nerve is located. And then obviously a really bad one is, make sure we do not cannulate arteries, people. All right. If you hit something and it's bright red and it goes spurting across the room when you pull your needle out, that's no bueno. That's bad. All right. You need to pull your catheter. All right. Apply direct pressure, lots of direct pressure. And very importantly, because the hospital is going to need to actually potentially treat the patient, all right, you need to notify the ER staff, the hospital, when you have a potential complication of an IV start attempt. Okay, so if for whatever reason you end up having a problem, you blow a vein, you hit a nerve, you cannulate the artery, whatever. Not only do you need to notify the ER staff to make sure they're aware of it so they can potentially treat it if necessary, you also need to document that in your pre-hospital care report. Don't forget that. That's important. Okay, some final points to keep in mind. All right, make sure you're priming your IV site, your administration set. All right, giving a giant air embolus to your patient because you didn't prime the tube. The tubing is bad. All right, that's a great way, surefire way to get a visit from CQI, QA, the men in black, whatever you want to call them. All right, bad stuff will happen. And then don't forget, all right, that we talked about the whole catheter shear problem. That potentially can cause a significant injury, potentially life-threatening injury to the patient, depending on where that embolus ends up, all right? The heart, the lungs, the kidneys, etc. All right, that's really important. So again, remember, once a needle has been withdrawn from a catheter, it should not, no way ever, be advanced again, all right, for risk of the catheter shear. And then just realize that some people do get anxious or have anxiety as regards needles. All right. So take that into account. All right. Be a compassionate EMS provider. All right. Treat them appropriately. Treat them like a decent human being. Treat them compassionately, and, have them lie down so they don't pass out on you. All right. Explain why you're starting the IV. Tell them that, you're going to be able to help them. All right. Deal with either their medical problem, like if they're having a heart attack, you're going to be able to administer medication. Or if it's a trauma patient, you're going to be able to, give them fluids to help replace the blood they've lost till they get to the trauma center. Okay. So that's important. All right. As a quick review with our IV therapy, remember, we start IVs for a medical reason. You need a valid medical reason to start an IV. All right. Either A, we have a medical patient, all right, and they're dehydrated, or we need to administer medication, or we have a trauma patient that needs volume replacement, fluid therapy, and or medication administration. All right. So we're either replacing fluid volume from, secondary to dehydration or hemorrhage, and or we need to administer medication. That's why we start IVs. All right. Make sure you're aseptic. All right. Make sure you're following BSI, you're wearing your PPE properly, and make sure you wash your hands afterwards, people. This is not rocket science. 20 seconds, warm water, sing happy birthday twice. All right. You need to scrub the fronts, the backs, in between the fingers, fingertips, thumbs, and the wrist, people. All right. You need to wash your hands. All right. And don't forget, make sure you're actually following the rules, following your protocols. All right. And make sure you want to try to minimize those potential complications from IV therapy, like catheter shear, hematomas. All right. Make sure, if you blow the vein, put direct pressure on it, put a dressing over it. All right. Notify the ER staff and make sure you document properly. And then don't forget, which extremities do we use preferentially when we start IVs? Arms or legs? Arms, people. Good job. All right, our final topic for today is going to be general pharmacology for paramedics. General pharmacology for paramedics. We have three main topics. We're going to describe drug names, their classifications, and talk about the federal piece of legislation that controls pharmacology here in the United States, or the Controlled Substance Act. Second, we're going to describe the routes of medication administration, which ones to use, the advantages and disadvantages of each. And then finally, we're going to describe the uses for various categories or types of common pre-hospital medications. All right. What is pharmacology, people? This is a review, but by definition, pharmacology is the scientific study of how various substances, chemical substances, interact with or alter the function of living organisms, i.e. us, people. Right? Now, there are four drug names, people, four drug names, and hint, hint, nudge, nudge, wink, wink. You may see stuff like this again in the exams or the quizzes. All right. The first is the chemical name, and that's the esoteric, really nerdy chemical name. All right. That involves the molecular structure and a description of that molecular structure of that specific chemical. All right. The second drug name is the generic name. That's usually like a shortened or abbreviated version of the chemical name. The third name, which is the one a lot of people use, is the official name, or it's usually the same as the generic name followed by the letters USP or NF. And then finally, the most commonly used name is the trade name. That's the one used by the manufacturer, whoever made the drug. All right. Now, the CSA, or the Controlled Substance Act, that's the federal piece of legislation that classifies and regulates the use for various pharmacologic agents, specifically drugs that either A, can potentially harm people, all right, pose a threat to people, and or pose are addictive, okay? So the CSA regulates and controls the use, storage, and administration of various drugs that either potentially can harm people and or pose a threat of addiction. It was originally created in 1970, and then it's subsequently been updated. All right. So again, we're dealing with drugs that either potentially can injure people, all right, or kill them, and or have the potential for abuse, and patients can end up being addicted to them. All right. Now we have five schedules. All right. Schedule 1. All right. That's the one you definitely need to know. Schedule 1 drugs are drugs which, by definition, have no approved medical use. All right. None. All right. So we as paramedics in the pre-hospital care environment should never, ever, ever, never, 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 ever, ever administer Schedule 1 drugs. An example would be heroin. All right. PCP. Okay. Those are drugs we should not be giving because they have no approved medical use. Now, realize that this is federal legislation. This is at the federal level. So, for example, you need to realize that even though marijuana may be legal in your state and in various other states, all right, at the federal level, marijuana is still considered to be a Schedule 1 drug. And that obviously can have implications for medical providers. All right. Then we go from Schedule 2 to Schedule 5. Schedule 2 are medically approved drugs, but they also have the highest potential for harm and abuse. And then you get, as you go down the schedule, Schedule 3, Schedule 4, Schedule 5, those are medical drugs that have various lesser degrees for potential for harm and abuse. All right. So Schedule 2 drugs are those that have a high abuse potential, but they still have a legitimate medical purpose. An example would be fentanyl, all right, for pain control. Schedule 3 drugs have a moderate level of abuse and or potential harm. An example would be ketamine. Schedule 4 drugs have a lower potential for abuse, all right? And examples would be the benzodiazepines generally, like midazolam, diazepam. And then finally, Schedule 5 are drugs that form the lowest potential risk for abuse and harm, all right? So they're still regulated, but generally speaking, the potential for abuse is pretty low. An example would be cough medications that have narcotics in them. Now, we're going to go over various categories of medications. The first category we're going to go over are respiratory medications, and we have various medications that are used to treat various medical conditions that can cause respiratory distress, cause dyspnea, such as asthma, COPD, for instance, okay? And so we have beta agonist drugs like epinephrine, albuterol, and they're generally used for their bronchodilatory effect. They have other effects as well, but that's one of their main beneficial effects. Then you have the mucokinetic bronchodilators, which also dilate bronchioles and the bronchi, but they work in a different manner. An example would be Atrovent. And oftentimes those drugs will be used synergistically together, such as with Combivent, which has both albuterol and Atrovent together. In addition to that, you have corticosteroids, which are very powerful drugs. They have a really strong anti-inflammatory property. And examples of those would be methylprednisolone or dexamethasone, for instance. Finally, we have drugs that are used in specific circumstances, like you have various minerals like magnesium sulfate, which is used, with refractory respiratory distress conditions, okay, like asthma, for instance, okay. Finally, we have, medical grade oxygen, all right? Remember, we want to maintain our patients' proper SpO2 or oxygen saturation levels. Follow your local protocols, but generally we want to keep them anywhere between 94, 95%, up to 99, 100%, depending on your protocols and the patient's condition. Cardiovascular medications or drugs that are going to affect the circulatory system and or the functionality of the heart. all right, and its various pumping mechanism and or it's the heart rate and or heart rhythm. Now there's 4 categories. All right, we have class 1 drugs that actually typically act as antiarrhythmics, such as lidocaine. And the way those drugs work, the dynamics of that is that it's going to affect the movement or slow the movement of sodium through the sodium-potassium pump channels. Then you have class 2 drugs, such as beta blockers or beta adrenergic blocking agents. An example of that would be metoprolol. Then we have class 3 drugs, all right, which increase the repolarization phase of the cardiac cycle. And typically those also act as antiarrhythmics, such as amiodarone. Finally, we have our calcium channel blockers, our class 4 drugs. An example of that would be diltiazem. Now, we have other types of drugs that we're going to use for various conditions, all right, that also involve the cardiovascular system. We have anticoagulants, all right, that inhibit the function and or action of clotting factors that we talked about, for instance, okay, while enhancing the action of natural fibrinolytics, such as heparin. An example of that would be, example of an anticoagulant would be heparin. Now, the medical conditions for that, okay, we want to make sure if we have patients, that are dealing with potential clots or thrombi, that could cause a problem, all right, from a medical standpoint. And so our anticoagulants will help deal with that condition. We have our antiplatelet agents, such as aspirin, which are going to inhibit platelet aggregation, okay, and also help our medical patients. An example would be our myocardial infarction patients. And then finally, we have our fibrinolytic medications, which dissolve blood clots that have already formed, all right? And so remember, we have medical patients like our CVA, our stroke patients, or our myocardial infarction patients that might very well benefit from the use of these various drugs, such as, a good example would be our fibrinolytic medications, such as TPA, for example. Right? Now, remember, okay, we're in the 21st century, people. All right, we should be providing for pain control in the pre-hospital care environment. All right, if your patient has a broken leg, all right, you should be giving them analgesics or pain control medications. Some basic concepts to keep in mind. All right. Remember, all right, if you, and it's not always practical in the pre-hospital care environment, in the 911 setting, but if you can provide preemptive analgesia or give the pain control meds before that patient starts hurting or before you cause a painful procedure, they're going to be much more effective from a therapeutic standpoint. And or if you provide multimodal analgesia, where you provide pain control with different types of medications, your overall quality of pain control is going to improve dramatically. And that's because, various types of injuries or medical problems are going to, cause noxious stimuli via various pain control pathways. So if you provide multimodal analgesia via various different medications, together, they're going to act synergistically and block those noxious stimuli, block those pain impulses through more of the pain pathways. All right. So, for instance, you might, depending on your protocols and the situation, you might want to administer an NSAID or a nonsteroidal anti-inflammatory as well as an opioid. Okay. And we're going to talk about all the different types of medications shortly. Okay, so for example, 2 common categories of medications or analgesics we're dealing with are our opioids. Those are generally good for moderate to severe levels of pain. Examples would be morphine and fentanyl. In addition to that, we have prescription strength versions of non-steroidal anti-inflammatory medications, which not only act, to help reduce pain levels, but also reduce inflammation. All right. Examples of those would be Celebrex, Toradol, Mobic, etc. Like meloxicam, ketorolac, flurbiprofen, celecoxib, diclofenac. All right, those are all NSAIDs, prescription NSAIDs that can actually help your patients. Now, typically speaking, there are exceptions, but typically speaking, NSAIDs work for mild to moderate levels of pain. And again, you can use them synergistically together a lot of times, which will help improve the quality and the efficacy of your pain control. And remember, don't forget, okay, just as a little side note, there are other ways to control pain besides pharmacologic methods. All right, don't forget, if you got a patient that has fractures, immobilize that fracture, splint that fracture, so you don't have sharp broken bone ends moving around inside that limb, lacerating blood vessels, nerves, causing more trauma, causing more pain, etc. All right, that's important. BLS before ALS, people. All right, our next medication is naloxone, Narcan, which is an opioid antagonist medication. All right, this is used to reverse, as we all know, narcotic overdoses. We all know, as EMS providers here in the United States, we're dealing with an epidemic of opioid addiction. And that opioid addiction epidemic only got worse during the global pandemic of COVID or SARS-CoV-2. All right, so we're dealing with this on a regular basis. Now, remember, with our opioid overdoses, why do our patients die from opioid overdoses, people? They die from respiratory depression. That's, generally speaking, how our opioids kill our patients. All right, they end up in respiratory depression, they end up apneic, and then eventually they end up in cardiac arrest if they're not treated properly. So, therefore, in the presence of a confirmed or suspected opioid overdose that's severe enough where you have respiratory depression, you have legitimate clinical signs, all right, my question to you would be, is there any contraindication to administering Narcan or naloxone in the presence of respiratory depression in a suspected or confirmed opioid overdose? And the answer is no. All right, you can't hurt them by giving them naloxone or Narcan, especially in that situation. So there's no contraindication, give it. All right, administer that naloxone and Narcan. And realize that when we're dealing with opioids like fentanyl, which are much stronger than our classic illicit opioids, such as heroin, you may need to administer multiple doses of naloxone or Narcan. In addition, you have patients that may re-narcotize because the half-life of naloxone or Narcan is a lot less than the duration of the effects of that drug, such as fentanyl. All right, so you may need to administer multiple doses of naloxone or Narcan. All right, and then finally, everybody take a look at that final bullet point there, okay, and realize that patients in cardiac arrest, remember your 5 H's and your 5 T's, if they don't respond to initial treatments such as defibrillation, et cetera, and your initial round of drugs, such as epinephrine, all right, and you suspect or have confirmed that that patient may have gone into cardiac arrest from a narcotic overdose, dealing with that potential toxin, one of your T's, all right, and always follow your local protocols, but administration of naloxone in a setting of cardiac arrest can be indicated. So just realize that can actually help save your patient by reversing that underlying etiology that caused the cardiac arrest in the first place. Then we have our anticonvulsant medications, obviously used to control seizures, especially in our epileptic patients, or our other patients that end up having seizures secondary to head trauma, hypoglycemia, etc. All right, follow your local protocols, follow your procedures, but generally our anticonvulsant medications are going to be used to treat and control and terminate seizures. Typically, the most commonly used ones in the pre-hospital care setting are going to be our benzodiazepines, such as diazepam or midazolam, right? And the reason why these drugs work is because they suppress the seizure center in the brain, all right, and reduce that overexcitation of our neurons, that generalized overstimulation of neurons in our central nervous system in our brain that are causing that seizure in the first place. So again, don't forget, with our medical patients, doing your full physical exam, getting your sample history is important, people. All right. You need to remember the basics. All right. If you have, taking your sample history and finding out, that patient that's seizing in front of you, do they have a history of epilepsy? And if they do, are they on seizure medications? And actually, are they taking those medications? Are they current? Because one of the most common reasons why our patients with epilepsy have breakthrough seizures is because for whatever reason, they're not taking their medications. They couldn't afford them. All right. They ran out of them. All right. They weren't able to refill the prescription, whatever the reason. All right. So remember that. Getting your history for these patients is important. Then we have our antiemetic patients. All right. We love antiemetic patients because we do not love our patients puking all over the back of our trucks. All right. Remember that. All right. So we have antiemetic medications used to control nausea and vomiting for whatever reason. You're going to have patients with chronic medical conditions like cancer, neoplasia. All right. Or you could have, remember, gastrointestinal distress. The clinical signs of nausea and vomiting are a generic, non-specific sign that there's something wrong. All right. And that can be, potentially either something wrong with the GI tract, something wrong with the central nervous system, etc. And so control of those clinical signs of nausea and vomiting is critical, not only for the welfare of the patient, and so we don't have to clean up the back of our truck, to be honest, but also, all right, remember, if you have patients that have altered mental status, altered levels of consciousness, they could potentially have an airway compromise if that patient vomits. All right, and then we can help prevent that problem from ever occurring by providing antiemetic medication. Our commonly used ones are promethazine, prochlorperazine, and my favorite, ondansetron. Next, we have our antihistamines. All right, typically we use those for our allergic reaction patients, especially our anaphylactic shock patients, our patients with severe allergies. All right, and obviously you want to follow your local protocols. And also you're going to provide other medications such as epinephrine, etc. But antihistamines are a good first-line drug for dealing with allergic reactions. Now there's two main types of antihistamines. You got histamine 1 antagonists such as Benadryl, and then you have histamine 2 antagonists, all right, such as Zantac, all right, and both of them block different chemical pathways that can help control severe allergic reactions. We have our diabetic medications. All right. Now, remember, with our diabetic patients, we're typically going to have either they're going to be hypoglycemic with a low blood sugar, or they're going to be hyperglycemic with a high blood pressure, such as our DKA or diabetic ketoacidotic patients. Now, typically, all right, the patients we're going to be treating in the pre-hospital care environment are going to be our hypoglycemic patients. That's the life-threatening problem. It's an immediate problem. And those we're going to treat, all right, either A, with dextrose, and the concentration of the dextrose you use is going to depend on the age of your patient, pediatric versus adult, and on your local protocols, and on, to be quite frank, what's available, right? So it can be 10% dextrose, 20, half strength dextrose, 25%, or, 50% dextrose. And you would administer that via the IV route. Or if you can't get IV access, then you can administer glucagon, all right, via the intramuscular route. And glucagon works indirectly to help raise the blood sugar by having the liver activate its sugar stores or its glucose stores via the storage form of glycogen. All right. So it's going to mobilize those glycogen stores, convert them into glucose, and then that's going to end up working to help raise your patient's blood sugar levels. So you're going to use dextrose if you have an IV, or glucagon if you have to go the IM route. And then our hyperglycemic patients, our high blood sugar patients, our DKA patients, typically we're not going to treat the hyperglycemia in the field in the pre-hospital setting. That's going to be done in the hospital. However, our DKA patients, we can treat. Those patients typically are dehydrated as well. That's one of the associated clinical signs we see with long-term chronic hyperglycemia or DKA. And so we talked about, pre-hospital fluid therapy. That's a situation where you might want to start an IV and provide them fluid therapy to help deal with that dehydration secondary to the chronic long-term hyperglycemia. All right, now talking about medication administration routes. And the reason why that's important from a clinical practical standpoint for medics is that the route of administration you give the drug to your patient, it can affect the onset of action. All right. Some routes of administration have a much quicker onset of action, especially in patients with poor perfusion, all right, such as cardiac arrest, critical trauma patients that are in decompensated shock, etc. As well as certain medications can only be administered via certain routes. Okay, so that's why this topic is really important. So we have two general categories. First is you have enteral routes or per os, all right, the PO route, all right, via the mouth or the GI tract. Then you have the parenteral route, which is anywhere except via the mouth or the GI tract. So for instance, you have IV, intravenous, IO, intraosseous, IM, intramuscular, or SQ or SC, depending on your medical terminology, the subcutaneous route underneath the skin. Those are the, some common parenteral routes of medication administration. Now, everybody take a look at this slide here, the points to keep in mind with the enteral route. It's very easy, okay? But remember, you can only give it to a patient that has a intact gag reflex. They need to be alert and oriented, all right, and have that intact gag reflex so they don't choke or you have a compromised airway. And the onset of action can be very variable, all right? It can take up to anywhere to 30 all the way up to 90 minutes for the peak effect for that drug to occur, depending on the status of the patient as well as the particular drug given. Remember, as a little side note, because we don't deal with pediatric patients as commonly as we do adults, don't forget, if you have infants that have seizures that you need to treat, all right, you can administer rectal diazepam or rectal midazolam as a benzodiazepine. That's an approved route, if you can't get IV access or IO access in those patients. Then we have our oral and nasal administration, all right? And these typically have a very quick onset of action, usually 5 minutes or less when you're dealing with a mucous membrane. So typically, mucous membrane, because they're highly vascular, they have a very good blood supply. You can either give medications sublingually underneath the tongue, such as nitroglycerin, or intranasal, all right, such as naloxone or Narcan. Both work great. They're very easy to administer and have a quick onset of action, even in our critically ill or injured patients. Then we have IV medication administration. This is typically the preferred method of administration for meds in critically ill or injured patients. It has a very quick onset of action in most circumstances, depending on the patient's perfusion level, their blood pressure, etc. The onset of action can be as quick as 30 to 60 seconds. All right. Typically, we're going to use this in critically ill patients, life-saving medications, patients in hemorrhagic shock where they need fluid boluses, all right, to achieve that level of hypoperfusion, all right, to maintain perfusion for our vital organs in our trauma patients. All right. Now, an alternative, we're going to talk about this, would be the intraosseous route. If you're not able to gain IV access, all right, you could also try IO or intraosseous access into the bone marrow. The onset of action are very similar, all right, 30 to 60 seconds generally. Now, everybody notice that fourth bullet point there, that fourth bullet point. Typically,
all right, to get the best, quickest onset of action, you need to flush your IV medication with 10 to 20 milliliters or cc's of IV fluids after you give those medications. And that's especially true with our cardiac arrest patients because they have poor perfusion. Don't forget that. IO, intraosseous administration. Remember, this is the go-to alternative method for critically ill or injured patients if you cannot gain IV access. It's usually very quick, it's easy, and it's not very time consuming. Follow your local protocols as to when you would pick and choose IO administration. But again, it's very quick, it's very effective, has quick onset of action, typically 30 to 60 seconds, okay? Our IO insertion sites would be the humeral head, the proximal tibia, all right? Those are the two most common. And remember, in cardiac arrest settings, you want to get as close to the heart as possible due to the poor circulation, poor perfusion. So therefore, the humeral head typically is the preferred site in cardiac arrest patients. Now, obviously follow your local protocols, but realize that there are some other sites that may or may not be permissible and or are considered controversial, such as the sternum, for instance. Okay, realize that, you know, that those have been used historically, but obviously you always need to follow your local protocol. All right. And remember, everybody take a look at that fourth bullet point. Any medication that can be given IV can be administered IO. That's important. Any medication that can be administered IV can also be administered IO or intraosseous. Then we have our subcutaneous or our intramuscular routes underneath the skin or into the muscle. All right. Those routes, so look at the differences. We're going to compare the two here. All right. So with subcutaneous medication administration in humans, we're dealing with very small volumes. All right. We don't have humans, you know, unlike animals, do not have a large sub-Q space. So typically we're dealing with 1 milliliter of fluid or medication or less. All right. The common sites are upper arm, the thigh, the lateral thigh, the abdomen, etc. And the onset of action can be variable. It's typically 15 to 30 minutes. All right. 15 to 30 minutes for sub-Q route, as long as you have decent perfusion. Versus IM or intramuscular route, where you can give larger amounts of fluid, up to 5 milliliters. You're actually injecting into muscle tissue. All right. And generally speaking, the onset of action is a little bit quicker. All right. It may be variable, but it's generally a little bit quicker at 10 to 20 minutes. 10 to 20 minutes typically. Our common IM access sites are lateral thigh. You can also do anterior thigh, the buttocks, upper arm, all right, or the shoulder region. And again, with both of these sites, because they're parenteral sites, all right, you need to be aseptic. All right, just like any of our parenteral medication administrations, all right, IV, IO, sub-Q, IM, etc. You need to be aseptic. All right, so make sure you disinfect those sites before you administer the medication. All right, in conclusion, we're wrapping up. All right, remember, all right, you need to remember the basic rules, people. All right, follow your local protocols regarding medication administration. Make sure when you're administering medications, you're aseptic, you follow your local protocols, all right, and follow the rules. All right, thank you all very much. I hope you learned something. Hopefully you had a good time. Thank you very much for spending this time with me. I wish you all the best. And if you have any questions, please go ahead and contact customer support, or if you have any problems, contact customer service. Via the help tab, you can fill out the online help form under the help tab, under the FAQs or the frequently asked questions section on your account page. Thanks a lot. Goodbye.